So this is the Exercise Science 220 lecture recording for ligament and tendon. Tendons and ligaments are both dense connective tissue with ligaments joining bone and tendons joining muscle with bone. They both consist of approximately 70% water, 25% collagen and 5% ground substance and elastin, leaving both with very similar mechanical properties to collagen, which in itself, as covered in the last video, acts something similar to rope. So it has a high capability of carrying tensile loads, but under compression tends to fold. The ligaments have marginally more elastin than tendons, and the fibers tend to be slightly less parallel, which leaves the ligaments being slightly less stiff and weaker than tendons. So as you can see here, the microarchitecture of ligaments and tendons are very similar. Both tendon and ligament injuries and derangements are common, and some of you may have suffered those yourself. There are also several factors that affect the biomechanical functions of both tendon and ligaments, including aging, pregnancy, mobilization/immobilization, diabetes, non-steroid anti-inflammatory drug use, and the effects of hemodialysis. So you can see here an outline of the role of ligaments. Now, ligaments usually provide support in one particular direction and often blend with the capsule of the joint. Both ligaments and joint capsules can be thought of as acting together as static restraints at particular joints. The main function specific of the ligaments being to guide normal joint function and to restrict abnormal joint movement. The maximum stress that a ligament can endure is related to its cross-sectional area, and ligaments also exhibit a viscoelastic behavior, a little bit similar to the sponge in water example used with cartilage, but obviously a slightly different composition with ligament. And this controls or helps to control the dissipation of energy and the potential of injury during movement. So with ligaments attaching to bones, it's important to understand what happens at the end of each ligament, and the attachment to bone is not just a simple change in tissue as people would imagine. There's actually a transition, and that transition happens through a few layers of calcified and uncalcified fibrocartilage, and that transition period supports that connection between the bone and the ligament and stops the fibers in the ligament from fraying at the ends, securing them into the bone. Obviously, on the ligament side of the attachment, there is much more strain able to occur before breakage, whereas bone undergoes a lot less strain before breakage. So if we take a closer look at the stress-strain relationship of ligaments under tensile loading, we can see here that the properties of the relationship mirror that of collagen, which dictates a lot of the mechanical properties of ligaments. And you've got that toe region where the material is straightening out, and that tends to happen, or that sort of loading tends to happen in activities like walking and jogging. And then as we experience higher loading or more loading in activities like landing and cutting, then we start to go through the linear region of the stress-strain relationship in tensile loading, and higher loading will start to cause microfailures right up to a complete failure. When that damage does occur at ligaments, we can grade that damage either as known as tears or strains, and grade 1 is a partial tear, grade 2 is a slightly more severe tear that usually results in some loss of stability at the particular joint where the ligament is held, and grade 3 is a complete tear with obviously subsequent loss in stability of the joint. However, interestingly, when we overload or place too much stress on a ligament, the subsequent damage isn't always in the ligament itself. Sometimes it's in the adjoining bone, which is known as an avulsion fracture. Now, this tends to happen when we load the ligament slowly, but with a large deal of stress. And when that happens, the energy is able to dissipate more in the ligament becomes stronger when we load it slowly, and therefore the bone is the weakest point. So it tends to happen more at the bone when we load it slowly. Also, these avulsion fractures tend to happen more in children than adults for a few other reasons. So now we discuss some of the general features of ligaments across the body. I want to talk about a few examples, and one that's a little bit of an exception to what we've been talking about as generally representing ligaments across the body is the ligamentum flavum that you can see in the spine. And if you look at the load elongation graph here, which is a variation of the stress strain, you can see that this operates a lot more like an elastic band. There's a lot more elastin in ligamentum flavum. So instead of acting more like collagen, which is like rope, it acts more like an elastic band. So you can see a lot of elongation for a little bit of load, and then very quickly it will develop into that plastic region and damage will occur. So another example I want to talk about is the ligaments that cross the knee. The knee is a really interesting example because we have a lot of load going through it, a lot of mobility is required, and when we do incur some damage across the ligaments of the knee, it can be particularly costly for people in terms of their movement, as well as for athletes as well. So we have the anterior cruciate ligament in the knee, we have the posterior cruciate ligament, and we have the two collaterals, the medial and lateral collateral ligaments. So if we take a look at the knee from the lateral aspect here, we can see how complex the arrangement is of the anterior cruciate ligament, posterior cruciate ligament, and the two leg bones, the femur and tibia. And you can see the cruciate ligaments with those bones form this crossbar action, and they actually change, or the crossover point of those ligaments changes as we go through flexion and extension, and that affects the support that those ligaments are able to provide in valgus, varus, as well as rotational directions of loading. So in addition to that, what we saw from the lateral aspect in the last slide there, you can see here that the anterior cruciate ligament not only changes alignment with respect to the posterior cruciate ligament as the knee flexes, but it also starts to, the insertions start to rotate, and therefore tension occurs differently, and it changes its shape as the knee flexes as well, making the arrangement and the effects of rotation and where your knee is positioned quite complex on the role of the anterior cruciate ligament. So it's not just the anterior and posterior cruciate ligaments at the knee that change how they support movements dependent on where the knee is in flexion extension. If we look at the medial collateral ligament here, you can see at full extension that both the anterior and posterior fibers are taut, whereas when we start to go into flexion, the posterior portion is relaxed, whereas the anterior portion of those fibers are the ones that are remaining taut and therefore still able to resist valgus and rotational stresses. So another of the purposes of this mechanical action that the complex arrangement of ligaments at the joint, at the knee joint provides, is to keep the menisci in contact with the condyles of the femur and the tibia. And this helps because the menisci are major load bearers in the knee joint. So with this complex yet important arrangement of ligaments in the knee, clinicians and researchers have been very interested in the type of loading that's required to cause damage at these ligaments, as well as the magnitude. And you can see here some joint displacement load graphs of understanding where the failure occurs. And we've been able to do this in research by testing, typically by testing primate knees within machines at different loading rates and different magnitudes, and understanding where the failure occurs. Here's another graph showing a similar pattern there of when that occurs with force elongation graph, and this particular one is taken from a study from human cadavers. So from primate testing as well as human cadavers, this research has been performed. So one of the aspects of loading the ligament that we've been able to better understand from this research is loading at different rates. And so a lot of the experimentation has been set up around loading those ligaments at a fast rate versus a slower rate. And you can see the difference in the graphs here. So the ultimate breakage tends to occur at about the same level of deformation, but we can get a little bit more load in maximum load before that break occurs. So if you can see here that where the two slopes actually start to split, that's around the region where we're seeing a change from elastic to plastic anyway. So maybe micro damage is not the same as ultimate failure here. And at the fast rate, you can also see a steeper curve through the elastic and plastic region, indicating that at faster rates, the ligament is slightly more stiff. So if you look carefully at the table here, again, you'll see a slightly higher linear load and maximum load that is capable of the ligament at faster rates. However, this is ultimate failure and not necessarily micro damage. So in addition to slightly different properties of the ligament at different loading rates, the different loading rates tend to have a large influence on where the failure typically occurs. So the tibia avulsion is actually that break in the bone that I described earlier, and you can see the ligament damage, and at a faster rate more of the damage tends to be at the ligament, whereas at a slower rate that damage tended to be at tibia avulsion, so therefore the bone was actually breaking at a slower rate of loading. So the key points or take-home messages from this last section in particular about ligaments is that ligaments, as well as tendons, are both dense connective tissue that consist approximately of 70% water, 25% collagen, and 5% ground substance and elastin, with the main function of ligament being to guide normal joint function and resist abnormal joint movement. Another key point is that the ligament-to-bone attachment reduces mechanical loading transmitted by the ligament to the bone, as well as understanding what this zone is comprised of. Ligament injuries can be termed strains or tears, as outlined earlier, and damage along those lines, so at different grading levels of strains or tears can cause different levels of instability and damage. So finally, we'll just quickly cover tendon, because tendons, as covered earlier, are very similar to ligaments in their makeup, but specifically the role of tendon is to attach muscle to bone, to help transmit that tensile load between muscle and bone, therefore producing that motion, as well as maintaining body posture. So with respect to the attachment between tendon and bone, the transition is very similar to that between ligament and bone. In fact, in many areas of the literature and from a mechanical standpoint, the transition here, the zones, are identical. So if we look at the stress-strain relationship of tendon in the tensile loading direction, we can see something similar here, again corresponding to the collagen fibers that largely make up tendon. The toe region typically it extends around 3% strain of the total length or the resting length of the tendon, with a linear reversible region of up to 5%, and the ultimate strain is about 8 to 10% of the resting length before we get failure. Of course, all of those can be influenced to some degree by hormones, stretching, and other potential changes that can be made physiologically to the tendon. When the tendon compliance is high, the change in muscle fiber length will be small compared to the length of change, or the length change of the whole muscle tendon unit. So as well as having high tensile strength and stiffness, tendon is resilient, having a relative hysteresis of 2.5 to 10%. So it has an ability to return energy. And the viscoelastic nature of tendons, so not as much as, say, cartilage, but there is some of that elastic area that you can pull, and then you get that elastic return, that storing of energy, can be used to increase the power of particular activities. So it is a site for it. It's perhaps not as much energy storage as is often thought of anecdotally when you're lifting and changing direction in tasks, but especially with high eccentric loads, it can be a very effective way of returning energy to the musculoskeletal system. So as with any other tissue in the body, tendons are sensitive to use. So the more that the more it undergoes stress and strain, the more the body will repair, and it will increase its mass and size of that particular tissue, and vice versa. If you have immobilization, then the tendon tissue can reduce. And this is a graph or a representation of that visually of the mass of the tendon. You can see if you go further towards the left hand side, the mass decreases with immobilization, and as we have more exercise and increased incidence of stress and strain, then that goes up. But the real mediator here, also bear in mind, is that the rest, or allowing the body to build up that particular tissue to increase its mass and therefore increase its strength of the tissue. And further highlighting that use it or lose it type of message with tendons, here is a graph showing what happens with the load versus elongation. So the ultimate failure point you can see here, similar to what we were looking at with ligaments before, in a control as well as in a group where it had been immobilized for 8 weeks. So this is in a condition such as when we break a bone and we're immobilized at a particular joint, we have a cast on, and if we don't use that, we can see that the ultimate failure point is much lower at a much lower load after immobilization. So it actually can happen quite quickly, this decrease in strength in tendons. And those quick decreases that we see from immobilization don't recover as well as you might imagine either. So you can see here further to the same study, we have a controlled 100% immobilization after 8 weeks is at 61% of the maximum value, so that's low to failure. And then we see improvements as the reconditioning goes on, but 5, 12 months, so even 12 months after that immobilization, after a year of reconditioning, we're still only at about 91% of our tendon strength to failure. So it does take a long time to recover from these short periods of immobilization. So finally, some more influences on the mechanical properties of the tendon, and in particular stress-strain relationship in tensile loading, are things like Achilles tendinopathy, eccentric training, and hormonal status. So particularly in females during contraceptive pill use or during pregnancy, the slope of that stress strain curve can shallow, so it becomes more elastic. The tendons become more elastic, less stiff, and they can have a lower ultimate failure point as well. So it is something that needs to be changes the way that loading occurs and should be taken into consideration. So finally, the key points with respect to tendon are that the main role of the tendon being to transmit tensile loads from muscle to bone, maintain body posture, and produce joint movement, that the bone attachment of the tendon has very similar zones to the ligament, that tendon has a relative hysteresis of only 2.5 to 10%, which makes it ideal for the storage of elastic energy, especially under high eccentric loads. Immobilization reduces the maximum strength of ligament, and this can be quite severe, up to about down to 60% within only 8 weeks, and that a 12-month rehabilitation program only restores about 91%. So that long period of time it takes for tendons to recover the strength from following an immobilization period.